Welcome to our comprehensive journey through infectious diseases, focusing on the principles of antimicrobial regimen selection and central nervous system infection. Infectious diseases remain a significant challenge in clinical practice, requiring timely diagnosis and effective treatment strategies. In this video, we'll explore the systematic approach to antimicrobial therapy, delve into the complexities of CNS infections, and review key clinical considerations. Whether you're a healthcare professional or a student, understanding these principles is crucial for improving patient outcomes and combating resistance. Let's begin by outlining the core topics we'll cover, setting the stage for a deep dive into each area. Our discussion will cover the principles of antimicrobial regimen selection, central and lower respiratory tract infections, upper respiratory tract infections, infective endocarditis, urinary tract infections, gastrointestinal and intra-abdominal infections, parasitic infections, osteomyelitis, septic arthritis, tuberculosis, and sexually transmitted infections. Each section will provide practical insights into diagnosis, treatment, and evaluation, ensuring a holistic understanding of infectious disease management. By the end, you'll have a solid grasp of both general and specific approaches to these complex conditions. Selecting the right antimicrobial regimen is often an empirical process, especially before the causative organism is identified. Infectious diseases are usually acute, and delays in therapy can lead to serious complications or even death. Empirical therapy should be guided by patient history, physical examination, and rapid diagnostic tests. This approach ensures that treatment begins promptly, reducing the risk of morbidity and mortality while awaiting definitive laboratory results. Let's explore the systematic steps involved in antimicrobial selection. A systematic approach to antimicrobial selection involves confirming the presence of infection, identifying the pathogen, selecting presumptive therapy based on the infected site, and monitoring the therapeutic response. Each step is critical to ensure that the chosen regimen is both effective and safe for the patient. This process minimizes unnecessary exposure to broad-spectrum antibiotics and helps prevent the development of resistance. Fever is a hallmark of infectious diseases, typically defined as a temperature above 37 degrees C. Oral temperatures range from 36.7 degrees C to 37 degrees C, with rectal readings being slightly higher and axillary readings lower. It's important to note that not all fevers are due to infection. Some can be drug-induced. Recognizing the pattern and context of fever helps clinicians differentiate between infectious and non-infectious causes, guiding appropriate therapy. Drug-induced fever is characterized by persistent elevated temperature without infection or other underlying conditions. This type of fever coincides with the administration of certain medications and resolves quickly once the offending drug is stopped. Common culprits include beta-lactam antibiotics, anticonvulsants, and several others. Recognizing drug-induced fever is essential to avoid unnecessary antimicrobial use and to address the true cause of the patient's symptom. During infection treatment, the use of antipyretics should generally be discouraged unless absolutely necessary. Antipyretics can mask a poor therapeutic response, making it harder to assess if the infection is resolving. Elevated body temperature, unless extremely high, is not usually harmful and may even aid the body's defense mechanisms. This approach ensures that clinicians can accurately monitor the patient's progress and adjust therapy as needed. Most infections lead to an elevated white blood cell, WBC, count, a condition known as leukocytosis. This increase results from the body's immune response, mobilizing granulocytes and lymphocytes to fight off invading microbes. The normal WBC range is between 4,000 and 10,000 cells per m3. Monitoring WBC counts helps clinicians assess the severity of infection and the effectiveness of therapy. Classic local signs of infection include pain, swelling, redness, tenderness, and purulent drainage. These symptoms are most apparent in superficial infection or those involving bones and joints. For deeper infection, such as meningitis or pneumonia, clinicians must rely on examination of tissues or fluids to detect inflammation. Recognizing these signs is crucial for early diagnosis and targeted treatment. Identifying the causative pathogen is a key step in infectious disease management. Whenever possible, samples should be collected before starting antimicrobial therapy. Gram stains and other rapid tests can reveal the presence of bacteria or mycobacteria. Delaying sample collection until after therapy begins can lead to false negative results, making it harder to tailor treatment effectively. Choosing the right antimicrobial therapy involves considering the severity and acuity of the disease, host factors, drug properties, and the need for combination therapy. Each clinical situation is unique, requiring a tailored approach that balances efficacy, safety, and the risk of resistance. Let's examine the key host and drug factors that influence regimen selection. Host factors play a major role in antimicrobial selection. Important considerations include drug allergies, age, pregnancy status, renal and hepatic function, site of infection, concurrent medications, and underlying diseases. For example, certain drugs may be contraindicated in pregnancy or require dose adjustments in patients with kidney or liver impairment. These factors ensure that therapy is both safe and effective for each individual. Understanding pharmacokinetics and pharmacodynamics is essential in antimicrobial therapy. Aminoglycosides and fluoroquinolones exhibit concentration-dependent killing, while beta-lactams are time-dependent. This means that dosing strategies must be tailored to maximize efficacy and minimize toxicity. Knowing how drugs behave in the body helps clinicians choose the most appropriate regimen for each infection. Antimicrobial agents must reach effective concentrations at the site of infection. Clinicians should consider tissue and fluid penetration, especially in areas like the central nervous system, urine, synovial, and peritoneal fluids. Additionally, some antibiotics can cause CNS toxicity or hematologic side effects if not properly dosed. Monitoring and adjusting therapy based on these factors is crucial for patient safety. Combination therapy is sometimes used to broaden coverage, achieve synergistic effects, or prevent resistance. However, it also increases the risk of toxicity and superinfection with resistant organisms. The decision to use multiple agents should be based on clinical need, balancing the benefits against potential drawbacks. Monitoring for adverse effects is especially important in these cases. Ongoing assessment is vital during antimicrobial therapy. Culture and sensitivity reports guide adjustments to the regimen, ensuring the narrowest effective spectrum is used. Monitoring WBC counts, temperature, and patient symptoms helps track progress. If anaerobic infections are suspected, therapy should continue even if organisms aren't identified. Radiologic improvement may lag behind clinical signs, so patience and careful observation are key. Switching from intravenous to oral therapy is considered when there's clear clinical improvement, no fever for 8-24 hours, a decreased WBC count, and a functioning gastrointestinal tract. Drugs with excellent oral bioavailability, such as ciprofloxacin, clindamycin, and doxycycline, are preferred for this transition. This approach reduces hospital stays and healthcare costs while maintaining effective treatment. If a patient fails to respond within 2-3 days, a thorough reevaluation is necessary. The cause may be non-infectious, non-bacterial, or due to an undetected pathogen. Other factors include drug selection, host issues, or laboratory errors. Identifying and addressing the root cause is essential to avoid prolonged illness and complications. Failures related to drug selection can result from inappropriate choice, dosage, or route of administration. Malabsorption due to gastrointestinal disease or drug interactions can also lead to subtherapeutic levels. Accelerated drug elimination is another possibility. Careful review of the regimen and patient factors helps identify and correct these issues. Immunosuppressed patients, such as those with chemotherapy-induced granulocytopenia or AIDS, may not respond well to therapy. Inadequate immune defenses can prevent infection clearance, even with appropriate drugs. Other host factors include the need for surgical intervention to drain abscesses or remove foreign bodies. Addressing these underlying issues is crucial for successful treatment. Resistance can be intrinsic or acquired. Intrinsic resistance means the drug never worked against the organism, such as vancomycin's ineffectiveness against gram-negative bacteria. Acquired resistance develops when bacteria mutate, rendering previously effective drugs useless. Understanding these mechanisms helps guide alternative therapy and prevent further resistance. Central nervous system, CNS. Infections encompass a range of conditions affecting the brain, spinal cord, and associated tissues. These include meningitis, encephalitis, brain abscesses, and cerebrospinal fluid shunt infections. CNS infections can be caused by bacteria, viruses, fungi, or parasites, and often require urgent diagnosis and treatment due to their potentially life-threatening nature. We'll now focus on CNS infections, covering their introduction, epidemiology, etiology, pathophysiology, clinical presentation, diagnosis, treatment, and evaluation of outcomes. This structured approach will help you understand the complexities of CNS infections and the rationale behind current management strategies. CNS infections involve the brain, spinal cord, and surrounding membranes. Meningitis refers to inflammation of the subarachnoid space or spinal fluid, while encephalitis is inflammation of the brain itself. These infections can be caused by a wide range of pathogens, each presenting unique diagnostic and therapeutic challenges. Acute bacterial meningitis affects approximately 1.2 million people globally each year, resulting in around 170,000 deaths. In the United States, mortality remains at about 15%, with 10–30% of survivors experiencing neurologic complications such as hearing loss or learning disabilities. These statistics highlight the urgent need for effective prevention and treatment strategies. The most common causes of bacterial meningitis are Streptococcus pneumoniae, Group B Streptococcus, Neisseria meningitidis, Listeria monocytogenes, and Haemophilus influenzae. Vaccines targeting these bacteria have significantly reduced the incidence of related infections, especially in children. However, vigilance is still required due to ongoing risks. Pathogens can enter the CNS through contiguous spread from nearby infections, hematogenous seeding from remote sites, direct inoculation during trauma or surgery, or reactivation of latent infections. Once inside, they replicate due to limited host defenses, triggering an inflammatory response that can cause significant neurologic damage. The host's immune response to bacterial components triggers cytokine production, particularly TNF-alpha and IL-1, leading to increased blood-brain barrier permeability. This allows immune cells to enter the CNS, causing cerebral edema and increased intracranial pressure. These changes are responsible for the classic symptoms of meningitis, including headache, neck stiffness, and altered mental status. Patients with bacterial meningitis typically present with fever, neck stiffness, and altered mental status, the classic triad. Other symptoms include chills, vomiting, photophobia, and severe headache. In children, additional signs like bulging fontanelle, apnea, rash, and convulsions may be observed. Recognizing these symptoms early is vital for prompt treatment. Seizures are more common in children with meningitis than adults. Kernig's and Brudzinski's signs may be present but are not always reliable, especially in young children. These clinical findings, combined with laboratory tests, help clinicians confirm the diagnosis and initiate appropriate therapy. Cerebrospinal fluid (CSF) analysis is essential for diagnosing meningitis. Elevated protein and low glucose levels in CSF suggest bacterial infection, but these findings can overlap with viral or fungal causes. Therefore, CSF analysis must be interpreted alongside clinical and other laboratory data for accurate diagnosis. The primary goals in treating CNS infections are to eradicate the infection, relieve symptoms, prevent complications, and reduce mortality. Early initiation of appropriate antimicrobials, along with supportive care such as fluids and analgesics, is critical for achieving the best outcomes. Effective CNS infection treatment requires antibiotics that penetrate the blood-brain barrier, appropriate duration of therapy, and sometimes adjunctive corticosteroids. Empirical therapy is started promptly and adjusted based on clinical response and laboratory findings. Maximizing antibiotic dosages ensures adequate drug levels in the CNS. Empirical antibiotic selection depends on patient age and risk factors. For infants under 3 months, ampicillin plus cefotaxime or an aminoglycoside is recommended. For children and adults up to 60 years, vancomycin plus cefotaxime or ceftriaxone is preferred. Older adults and immunocompromised patients require broader coverage, including ampicillin for listeria. Therapy is refined once the pathogen is identified. Once the causative organism is identified, therapy is tailored accordingly. For example, penicillin-susceptible N. meningitidis is treated with penicillin G or ampicillin, while resistant strains require cefotaxime or ceftriaxone. Other pathogens, such as listeria or pseudomonas, have specific recommended agents. This targeted approach improves outcomes and reduces unnecessary drug exposure. The duration of antibiotic therapy varies by pathogen. S. pneumoniae typically requires 10–14 days, N. meningitidis and H. influenzae 7 days, Listeria 21 days, and gram-negative bacilli at least 21 days. Adhering to these guidelines ensures complete eradication and reduces the risk of relapse. Corticosteroids like dexamethasone may be used as adjunctive therapy in bacterial meningitis to reduce inflammation and improve outcomes, especially in children with pneumococcal or H. influenzae infections. Timing is critical. Dexamethasone should be given before or with the first antibiotic dose. Its use in adults is less clear, but may be considered in suspected pneumococcal cases. Patients should be evaluated every 4 hours for the first 3 days, then daily. Clinical signs, microbiologic findings, and CSF analysis guide ongoing management. Early and regular assessment helps detect complications and ensures that therapy is effective, allowing timely adjustments if needed. Community-acquired bacterial meningitis is typically treated with ceftriaxone, and where penicillin resistance is common, vancomycin. Alternatives include benzylpenicillin and chloramphenicol. In patients over 50 or those with alcoholism, ampicillin is added for listeria coverage. Hospital-acquired cases and immunosuppressed patients require broader regimens, sometimes including acyclovir for possible viral encephalitis. Immunosuppressed patients, such as those with HIV or on high-dose corticosteroids, require more aggressive and prolonged therapy. Regimens often include ceftazidime, vancomycin, ampicillin, and sometimes acyclovir. Close monitoring and adjustment based on clinical response and laboratory data are essential for these high-risk individuals. Tuberculosis remains a significant infectious disease worldwide, affecting millions each year. CNS involvement, such as tuberculous meningitis, requires prolonged and specialized therapy. Early recognition and treatment are critical to prevent severe complications and improve survival rates. Summary: effective management of infectious diseases relies on timely diagnosis, appropriate antimicrobial selection, and ongoing monitoring. Special considerations are needed for CNS infections, immunosuppressed patients, and those with resistant organisms. By following evidence-based guidelines and adapting to individual patient needs, clinicians can optimize outcomes and combat the growing threat of antimicrobial resistance. As infectious diseases continue to evolve, staying informed about emerging pathogens, resistance patterns, and new therapies is essential. Ongoing education and collaboration among healthcare professionals will ensure that patients receive the best possible care. Thank you for joining us on this in-depth exploration of infectious disease management. For those interested in learning more, numerous resources are available, including clinical guidelines, textbooks, and online courses. Staying up to date with the latest research and recommendations will help you remain at the forefront of infectious disease management. Continue to seek out new knowledge and share your expertise with others. Infectious diseases present ongoing challenges, but with a systematic approach to diagnosis and treatment, clinicians can make a significant impact on patient health. Remember to consider host and drug factors, monitor response closely, and adapt therapy as needed. Together, we can advance the field and improve outcomes for all patients facing infectious threats.